thing so your feet aren't. So the first thing we're going to do is check one carotid at a time. And I'm feeling for the quality or the amplitude or the force of the blood going through the carotid. And we gauge that as being 0 to +3. 0 would be I don't feel anything in the carotid. +1, it's weak and thready. The poor guy is going into shock. +2 would be normal. +3 was he was late for the final exam and it's bounding. Okay? The other thing I want to get is whether the pulse is regular or irregular pattern. And then the third thing I'm going to get is the rate. Only on one side do you need to count the rate. You can count for 15 seconds, 30 seconds. Do not count for a full minute. The only place you do that is where? When we get the apical pulse. And I'm going to have my documentation sheet because I can't remember. He has a nice carotid pulse. I'm not going to count, but you know, I can feel the quality is +2 and it's regular. The next thing I want to do is check for a bruising sound over the carotid. And I'm going to use the bell of my stethoscope. And I'm going to ask my client to hold their breath. Go ahead and breathe. Hold your breath again. Breathe. You have your client hold their breath so you're not hearing breath sounds that can confuse you and say, that sounds like a bruising sound. Okay, so if they hold their breath, you shouldn't hear any blowing sound. What is a bruising sound? Huh? Yeah, but what does it signify? Yes, the blood going through is very turbulent. The next thing I want to check for is for pulsations over the internal jugular vein. So I'm going to turn his head slightly, and I'm looking where the clavicle is and where the sternomastoid muscle intersect. And I see it right, I don't know if you can see it.
Yep.
Huh?
Mm-hmm.
Okay, then turn this way.
Yeah.
Okay, so I would chart this as that pulsations noted in the internal jugular vein area. Okay, next I'm going to, remember I'm on the right side of my client, privacy here. Now I'm looking for any pulsations over the pericardium. Normally, in many adults, you'll see a pulsation over the mitral area, the point of maximal impulse, known as the apical impulse, and it would be in this area here. I don't see any visible pulsation, so that's what I would chart. But if I saw it, it's normal. The next thing I want to do is check for thrills and heaves, and I'm going to do it both at the same time. When I check for this, I'm going to again ask my client to hold their breath because the lungs makes the chest move up against your hand, and that would be normal. But if it's the heart that's doing it, I need to indicate that. That's not normal. So the difference between a thrill and a heave, a thrill feels like a vibration. Your book, Jarvis, talks about like stroking the neck of a cat when it's purring. That's what it feels like. For a heave, it's when the heart is pressing up against your palm, and that shouldn't be. It means the heart is overworking. So I'd like you to hold your breath for me for a second. And I'm going to do this very quickly. Okay. Breathe normally. There's no heaves, and there's no thrills, okay? Next, I'm going to do my auscultation, and here's where you have to be patient. And you're going to tell the examiner what you're hearing. You're just not going to move your stethoscope around, okay? You need to tell the examiner what you're hearing and what you're doing. So I'm going to listen over the aortic area first. And this is where I should hear an S2 sound. I can hear S1 as well, but the S2 sound is louder of the aortic area. And then I'm going to cross over and listen in the pulmonic area, which is also the S2 sound. What does the S2 sound mean? What's producing that sound?
Closing.
Okay, so we really have diastole where the heart is contracting, and that's why we hear such a loud sound. Okay, so the S2 sound is present. There were no extra heart sounds there. Okay. Next, I'm going to, right below the pulmonic area is Erb's point. This should also be an S2 sound, but you're also looking or listening to see if there are any murmurs in the aortic or pulmonic area. They'll be noted in Erb's point. Okay? Again, make sure I close my eyes so I'm concentrating. I don't want to hear noise. I want to listen for that S2 sound. And there are no murmurs. All I hear is an S2 sound. Next, I'm going to go to the tricuspid and then the mitral area. And this is where I'll hear the loudest, the S1. And what is happening with the S1? Okay. And that's when blood is filling the ventricles up, okay? And we can hear the S2 sound in the same place, but the S1 is louder at the tricuspid and the mitral. The mitral is right below the left nipple, okay? Right below the left nipple. I'm also, as I'm listening for any extra heart sounds, which would be an S3 or an S4. S3 is more common than an S4. And with elderly people, often we do hear an S3 because it's caused by extra fluid in the heart. People with congestive heart failure often have an S3 sound. It's added on to the S1, S2. S4, less common. It's when people have a very severe condition called pulmonary hypertension. You wouldn't see somebody in a clinic with that kind of condition. Okay? The other thing to keep in mind, if you're having a hard time distinguishing between the S1 and S2, I'll give you a trick that your book talks about. As you're listening to the tricuspid or mitral, which we said is S1, feel for the carotid. The carotid impulse is the same as an S1. Okay? So if you're having trouble distinguishing, you could feel for the carotid, that's an S1. It'll contract, you'll feel the pulsation at the same time as the S1. Thank you for your patience. When I get to the mitral area, I want to get an apical pulse. This is where I'm going to count with the second hand of my watch for a full minute. This will be important, I think, next semester when you take pharmacology and you're looking at cardiac drugs like digitalis preparations. When we're administering medications and you're giving a digoxin or lanoxin product, often on the MAR, medication administration record, the doctor will say, hold it if their pulse is below 60, and you get an apical pulse to determine that. Why? Because those kinds of drugs, the digitalis, digoxin drugs, tend to have a tendency to slow down the contractions anyway. So if someone is having a pulse of 54 and you give them digoxin, wow, they're going to be in trouble because it's really going to lower the contraction rate, okay? So we're going to pretend that I got an apical rate. Hopefully it was similar to my carotid, and I'm just going to make up that it was 64 and regular, and it was +2. Now what I'm going to do is turn to the bell of my stethoscope. I still have it over the mitral area, and I'm going to ask my client, to turn a little bit to his left side, not off the exam table. And I'm going to listen for any murmurs or extra heart sounds, because it'll be easier to hear. Now the heart is closer to the chest wall, and I'll be able to hear them better. Okay. And there aren't any extra heart sounds or murmurs. Okay. All right. While I'm here, I'm going to check for the radial arteries. +2. And while I'm here, after I feel for the pulse in the brachial area, +2. Just relax. It's where you'd be taking a blood pressure. +2. While I'm in the upper extremities, I'm going to do the Allen test, which checks for the patency of the ulnar and radial artery. So maybe if you just sit up for this, I normally wouldn't have you do that, but just so they can see. I want you to make a fist for me here. And I'm going to put pressure with my thumb on the radial and ulnar artery. Then I'm going to release one. I'll release the ulnar one first. Open up your hand. And I'm looking to see how quickly the blood returns to the palm. Close it again. Okay, open up your fist. People who have circulatory problems, maybe heavy smokers or people with Raynaud's disease, Berger's disease, often have sluggish return of blood flow. And I would do it on this side as well. Like this. Again, I'll do the ulnar side first. Okay, see how quick it is? Okay. Then I'm going to be checking the femoral pulses. Relax again. I'm just going to unbutton your thing here a little bit. Does it snap or?
Sorry.
All right. I won't get too cozy here. Well, I'm feeling with 3 fingers of each hand for the femoral pulse. And again, it's +2, and I do the same on the other side. Just get up this way a little bit. Now for the popliteal, no, just relax. You want to have them flex their knee, and you're feeling again with the fingers of each hand. But if you don't feel something, I can't feel most people with their popliteal pulse, even if they're thin as a stick. You'd have to have a Doppler available. So don't lie. If you don't feel the pulse in any of the places that you're testing for, put non-palpable, okay? And I would do the same on the other side. Then as we work our way down, can I ask you, I hate to ask that you can put your shirt back on, but I'd like you to take your shoes off. Okay? Because we're working our way down.